Hey everybody, welcome back to my channel. In this video, we're going to be talking about what to expect during your in-office ear tube evaluation and procedure, including discussion of the risks and the procedure itself, step by step, so you'll know exactly what to expect. Okay, let's get started. First, I'll sit down with you and your child and review the child's medical history. You will explain what has been going on with your child and what concerns you have. And if there's been any testing, like a hearing test, we will review that together as well. I will examine your child and look in the ears, and then we will discuss the options. If you're considering office ear tubes, I like to determine if the child is a good candidate. Things that make a good candidate are anatomy. Does the child have an abnormally small ear canal? That would make it hard to perform the procedure in the office. If the child is older and too large to swaddle, are they comfortable having their ears examined? If they're extremely anxious or if they have sensitive ears, they might not be a good candidate. And then for older kids, we may also discuss if there are any underlying factors that could be contributing to the child's eustachian tube dysfunction. We might discuss whether or not allergies are playing a role and if combining tubes with other procedures could be helpful, like an adenoidectomy or balloon dilation of the eustachian tube. What to expect for in-office ear tubes specifically, meaning tubes are placed in the office. No fasting is needed, but I also don't recommend a full stomach right before this procedure. So some food, but not a large meal. And then you'll give the child a dose of Tylenol or Motrin about 1 hour before the procedure. We will then review the consent form. Risks of ear tubes include bleeding, infection, scarring, early extrusion, a retained ear tube, clogged ear tube, a tympanic membrane perforation, hearing loss, a medialized ear tube, or a phenol burn. Most complications are minor or self-limited. A persistent tympanic membrane perforation, a hole in the eardrum, is the most likely complication to require an intervention, and the surgical closure rates are between 80 and 90%. So let's break those down. So bleeding, infections, and scarring are inherent to any surgical procedure. Bloody drainage from the ear after surgery is common and does not require intervention. Bleeding requiring intervention is very rare. Infection can still happen even in the presence of tubes. Typically, the infection is able to drain out of the middle ear rather than being trapped behind the eardrum. That's part of the tube's job. And treatment with topical drops rather than oral antibiotics is typical. The incidence of this ranges from about 10 to 20%. Scarring, which we call meringosclerosis, is common and is reported in about up to 30% of patients, but it does not typically cause hearing loss. The tubes are expected to stay in place for about 6 to 18 months. 12 months is about average. They can fall out early and they can stay in too long. The rates of early extrusion range from about 4 to 8%. And if a tube is still in place after 2 years, we call this a retained tube, and we might talk about pulling it out. This happens less than 3% of the time. A clogged or obstructed tube occurs in about 6 to 8% of patients. Sometimes hydrogen peroxide can be used to clear the tube, but in some cases the tube needs to be replaced. After the tube falls out, usually the eardrum heals up on its own. There's a small chance it can leave a little hole behind in the eardrum after it falls out that may need to be patched. The rate of a tympanic membrane perforation after an ear tube is about 1 to 3%, and if surgery is required to patch the hole, the success of that surgery is about 80 to 90%. Sometimes the tube can fall behind the eardrum and into the middle ear when it's being placed or when it's extruding. And if this happens, we might leave it in the middle ear. It may extrude on its own over time. The tube is made of silicone, and in many cases, it is safer to leave it than to try to retrieve it. This is very rare and occurs in less than 0.5% of patients. Hearing loss is uncommon, but having a tube or a hole in the eardrum can cause some hearing loss. This is not a permanent hearing loss. Tubes can cause a small shift in the hearing threshold that is usually not clinically significant, meaning it is not noticed by the patient. A chemical called phenol is used to numb the eardrum for office procedures. And if this chemical accidentally touches the skin, it can cause a chemical burn. This is very rare. Now, after we have reviewed all of those risks and signed the consent form and all questions have been answered, we then move to the procedure room. The patient is laid down on the exam chair, which is flat like a table. If the child is very young and unable to hold still on their own, then they will be swaddled with a blanket and then wrapped with a papoose immobilization board. This has Velcro straps that just help secure the patient so that they cannot easily wiggle out of the swaddle, and so that their caregiver does not have to physically hold them and wrestle with them during the procedure. If they are older, they simply lay back in the chair. Now, my assistant sits at the head of the chair and helps hold the patient's head. I sit down on one side, and the parents or the caregiver are going to sit on the other side. I will use a microscope and a speculum to view the patient's ear, and the parents can show the child a phone or a tablet or comfort the child in any manner of their choosing. Some parents like to sing, and others simply offer comforting words. And first I will remove any earwax that's blocking my view. And then once I have a good view of the eardrum, called the tympanic membrane, if we're using the hummingbird device, I will numb the eardrum with a medication called phenol. The phenol is placed on an applicator and touched on the surface of the eardrum. So it's topical, it's not an injection. It works instantly, and it does cause some stinging, burning, kind of warm sensation that lasts a few seconds. And this is the only part of the procedure that is painful. If we're using the tula system, then the earpiece will be put in place in the ear, and the ear canal will be filled with the lidocaine solution, and it will be turned on, and it will run for 10 minutes. Sometimes the current that is helping the lidocaine numb the eardrum is painful or uncomfortable. And so if the patient tells us they're in pain or uncomfortable, then we just turn down the setting, which causes the numbing procedure to take a little bit longer, but it makes it more comfortable for the patient. Once the eardrum is numb, then the device is used to puncture the eardrum and place the tube. If the tube is in good position, then we move to the other side and we repeat. If there is movement when the device is deployed, the tube may be sitting on the eardrum instead of through and spanning across the eardrum. If this happens, we call it a short shot. And I will remove that misplaced tube. I'll use another device and go again in the same spot. If the tube falls behind the eardrum and it falls into the middle part of the ear, I will retrieve it if I can safely do so. Otherwise, I will leave it there and I will use another device to deploy a new tube in the correct position. Once the procedure is completed, the patient is removed from the swaddle and placed in their parents' arms. They can leave the clinic and resume regular activities immediately. There is minimal pain after the procedure. I usually recommend Tylenol or Motrin if the patient seems fussy or voices any discomfort. I typically prescribe antibiotic ear drops for the first week. And during that first week, I also like to keep the ears dry, meaning no swimming, no submerging the head underwater when bathing, just keeping the ears nice and dry for that first week. And then after 1 week, it's okay for any clean, treated water to get into the ears. If they're going to be swimming in a natural water like a lake, river, or ocean, then they need to wear earplugs. And patients will usually follow up with me in about 6 weeks to check the tubes. Again, the tubes are typically in place for about a year on average. And for most patients, the tubes will extrude, the drum will heal, and then they're done. I hope you have found this helpful. If you have questions, please drop those in the comments below. And don't forget to like and subscribe. I will see you next time.